Hi, I'm Lauren Malinczak, a kidney and pancreas transplant surgeon, the director of H6, where you will stay as a transplant patient at Henry Ford. The Henry Ford transplant team consists of 8 transplant surgeons. Dr. Kim, Dr. Denny, and I do most of the kidney transplants. After surgery, most patients go to H6, the transplant surgery floor. The team there is very familiar with taking care of transplant patients. By day 1, you will be out of bed, at least to a chair. Your team will assess the function of the kidney transplant and need for dialysis every day. You may need an ultrasound. You will be able to drink if you're not nauseated. By day 2, you'll be out of bed, walking, back to eating and drinking as you tolerate it. You and your support will learn about your medications for home. By day 3, your catheter will be removed. After, you can urinate on your own. Your drain will be removed. Discharge plans will be finalized. While you're in the hospital, the clinical team will be watching for complications. These complications can be categorized as bleeding, thrombosis, infection, fluid collections, or problems with the ureter or bladder. In addition to getting infection from the kidney, patients can acquire infections in the hospital, such as pneumonia, blood, or wound infections. Bleeding complications can include bleeding from or around the kidney transplant. Blood transfusion is needed in about 20% of patients who undergo a kidney transplant, more so if you're starting the surgery with a low blood count. About 2 to 4% of patients will return to the operating room for bleeding complications. Those numbers can double if you need blood thinners such as warfarin or Plavix. We do not transplant deceased donor kidneys into patients taking medications such as Eliquis. Thrombosis is when blood clots. Blood can clot in or around the kidney, leading to loss of the kidney transplant in up to 4% of patients. If this occurs, the kidney would need to be removed and you would return to dialysis. You can also get blood clots in veins, such as your legs or pelvis, or in your lungs. This kind of blood clot would need to be treated with blood thinners. The best way to prevent blood clots in your legs is to wear the sequential compression devices while you are in bed, ambulate as soon as possible and frequently after surgery, and you will be given a blood thinner, heparin, under your skin 2 to 3 times a day while in the hospital. We will be watching for symptoms of infection daily. If you are heavier or diabetic, you will be at higher risk for wound infections. Sometimes you may be asked to lose weight or get better control of your blood sugar prior to transplant to reduce this risk. Ureter complications can include leaking at the site of the connection, or the connection can scar down and become too tight for urine to pass through. This is known as stenosis. Bladder complications can occur when you have difficulties with urination after transplant. A variety of issues can occur, such as bladder spasms, which can be painful or irritating, frequent urination, urinary incontinence, urinary retention, which may require catheterization, or the urine stream may be blocked by a large prostate. Most, but not all, urinary and bladder complications can be managed with treatment that doesn't require repeat operation. Hernias can occur after open kidney transplant due to the location of the incision, being overweight, or requiring immunosuppression. To prevent this, you may be required to lose weight prior to surgery, be given an abdominal binder to wear to reduce strain on the wound, and you will not be able to do any strenuous activity or lifting anything greater than 10 pounds for 2 to 3 months after transplant. At the end of 1 year, our expected patient and graft survival is approximately 95 to 97%. At the time of transplant, you will start anti-rejection medications through an IV in the operating room. You will need to take anti-rejection medications by mouth twice daily for as long as you have the transplant. You will start with larger doses, and these doses will taper down over the first 3 to 6 months after transplant. These medications have side effects. Most commonly, they cause GI upset, diarrhea, skin and hair changes. One of these medications we give you is called tacrolimus. This medication must be kept within a certain range. If it is too low, you will get rejection, and if the dose is too high, certain side effects like headaches, shaking, and even seizures can occur. Overall, these medications reduce your body's ability to fight infection and cancer. It is very important to learn from patients already living with transplant how to live safely in your community. After transplant, you will need your support people. They will help you with everything from your discharge instructions, medications, transportation, to attending your clinic visits with you. You won't be able to lift anything heavier than 10 pounds, so you'll need help with laundry, dishes, cooking, and other daily activities. You'll be able to shower, but no baths, hot tubs, or swimming pools are allowed after transplant. You'll be able to take a bath once your incision is completely healed. You'll be attending clinic about twice weekly for the first couple months after transplant. When things become more stable, you will see us less and less. Plan to take about 3 months off if you're working. We want to answer all of your questions to help you move forward with confidence toward the day of your transplant. Please don't hesitate to reach out for any reason as we move through the process. Thank you for watching and for choosing Henry Ford Health for your care.